profiling, bundle payments. All of this stuff is us, what we're dealing with. And, you know, basically it's damned if you do, damned if you don't, you know, but which one are you going to choose? But we're sort of stuck. And Sandy implied, what is the question here? Can registries actually help us? Well, if we have the right data elements and definitions, we collect the correct clinical data, as Eric says, and have a good observational database, maybe we'll be able to do accurate quality assessment, quality improvement, and also allow clinical research. In fact, this AHA policy statement led by Vince Buffalino outlined recommendations in expanding existing and future clinical registries. Now, Sandy pointed out that we started in 1998 with the Cath PCI registry. We now have 7 registries. And as Sandy pointed out, we're in 2,500 hospitals, 1,000 cardiologists participating in the Pinnacle Outpatient Registry, and 17 million patient records. There may be some people here that actually aren't totally sure how it works. And as Sandy correctly pointed out, it's a hospital actually makes a contract with the NCDR. Now, the SDS is different, because the SDS, both the physicians and the hospital make a contract. So we're actually dealing with this going forward, particularly if we start taking on the concept of physician-specific data reporting, which has been asked for by clinicians and hospital systems. Then clearly you're going to have a contract with clinicians. You sign up with a certified health software vendor, you submit data, and you get quarterly benchmark reports. The mission is to improve the quality of cardiovascular patient care, providing information, knowledge, and tools, implementing quality initiatives, and supporting research that improve patient care and outcomes. But basically, this mission aligns with the ACC's mission. We want to improve our patient care and outcomes. We can do this through and generate quality, education, and knowledge generation, all through the registries. Now, an important point sometimes missed is that the registry isn't ACC NCDR. It actually is a compendium of multiple subspecialty and specialty societies that participate in it. If we don't have a broad tent, it's not going to be successful. And I think this is one of the strengths of the registry. So what if the registry offered a bunch of tools? What if it offered the ability to really do good benchmarking? What if it was able to do really good quality, appropriate use criteria, understanding guideline adherence, understanding hospital and physician level performance measures? What if the registry can meet physician needs for the PQRS system, Physician Quality Reporting System, which leads to differential reimbursement for the demonstration of quality? What if we can be able to help in value-based purchasing? How about the area of maintenance of certification in terms of for ABIM, and issues related to CME, which now increasingly requires performance improvement? What if? Well, we do it. And this is, again, value added to the profession. When we launched it in 1998, we were one registry. We were focused on quality and quality improvement and supporting local QI at the hospital level. Now we've grown, as we have 12 societal partners. We have 150 publications. The FDA uses us for post-market surveillance. Health plans, state, and governments have adopted us. But our future, and this is important, we got to be incorporated well into the workflow. We can't have data, we can't have registry fatigue, entering data downstream. It's got to be extracted directly from our electronic records. Our registries shouldn't be standalone. They should be totally integrated. Patients go from ACS to Cath PCI to ICD. So we got to be on a single platform. We need point-of-care tools, just like it was talked about earlier, so that are in the workflow. We need to be fully integrated with structured reporting that meets meaningful use. We need to support fully maintenance of certification and learning and lifelong learning. And this is our direction and where we're going. We have a lot of registries and registry studies that are used for analytics, research and publication, and quality improvement. I won't bore you with our governance, but it's a very robust organization with over 200 of outcomes researchers in the nation that are participating and populating our various committees, whether they be the steering committees, research and publications, or QI committees, or science and oversight. Now, why do hospitals actually participate? Why do you participate? Because you get online dashboard and benchmarks, you meet regulatory and payer requirements, it offers the internal QI portion, there's site training and orientation, and a data quality program. Now, next we need to come up with really good IT platform and data alignment and data element alignment. And this is really where we're going, because again, we have to be seamless and have to be fully integrated. And so we're working with vendors to create systems that avoid this redundant data collection with the common elements. And I think we'll be there very shortly. Well, what about the data quality issues? There's been a lot of attacks on the quality of the data within the NCDR. How do we ensure the data is high quality? Well, first of all, the first comment is the data is your data. So you're responsible for the data. You can't blame it on someone else. So we need, and I'm sure a great discussion can be had later on in how we can ensure that we enter high quality data. We talked about the concept of prospective data entering, but also the physician engagement. And I think one of the biggest problems related to the ICD story from last January is two. One, the paper was talking about more focused on the CMS coverage with evidence development, which had criteria that didn't necessarily fit all the right clinical indications that electrophysiologists actually implant things. So that's implanted defibrillators, so that was one issue. But in all honesty, the electrophysiology community hasn't been engaged up to that point with the data entry. I think we've been a little ahead in the cath PCI realm, but I will tell you, and I'm sure Eric will tell you, that electrophysiologists have become very interested in the quality of the data being put into their ICD registries now and working on ways to try to do that. We have training and clinical support teams through online webinars, FAQs, customer support that's live, webinars, data entry integrity, that is, as the quality analysts know, in terms of data completion, value checks, range checks, and parent-child fields, data quality reports related to algorithms and predetermined levels of completeness, internal data QI protocols that hospitals have taken on. And then we have an actually external audit program where 300 to 625 records are audited annually with 25 random sites. So what is actually the results of the audit? And I think this is kind of surprising. So the audit was done on elements that are important, elements that determine risk-adjusted mortality, elements that determine whether an ICD is appropriately placed by the evidence for primary prevention. And this is in press, it's going to be published, I guess, this month. But when we did this analysis, looking at cath PCI, ICD, and action get with the guidelines, the accuracy of the data abstraction was 90%. So it's not as bad as we think. Obviously, opportunities for improvement, certain elements in particular are more inaccurate than others. But the good news is not as bad as we think, or a lot of people think. We need to have more audit collaborations. We've done this between the NCDR and the sites, the NCDR with states. There's states, for example, that mandate participation and have their own robust auditing, Massachusetts being the prime example. And there's also been in Ohio regional programs where regions have gotten together to be able to assess accuracy of data completeness with each other. So that might be a strategy even worth talking here as a way to ensuring data quality. Now, the reporting services have become important. It used to be, again, a local QI initiative, but now hospitals and probably eventually physicians are going to want to give us permission. In other words, we can't hand out the data at the NCDR to anyone without your formal written permission to give it to third parties, whether they be health plans, whether they be state and federal regulators, whether they be, like for here, regional QI efforts, or public reporting, which is not around the corner. The train has left the station. So to give you some examples, the Action Get With the Guidelines Registry has a lot of QI activities, but there are third-party reporting collaborations that occur in states of Maryland and also up in Washington, Mission Lifeline with North Carolina and Dallas, and South Carolina and Texas. Payers, Blue Cross Blue Shield has one. Health Synods and Tenet also has ways of differentiating centers with excellence through this participation. Cath PCI, again, you see all the training and QI activities and the collaborations that occur statewide, payer-wide, health systems-wide. Care Registry, the Carotid Registry, now is going to be incorporating all peripheral stenting, that is both legs and aortas shortly. ICD Registry, well, by definition, all the data goes, at least for primary prevention, goes to Medicare, and they're the major payer, of course, for primary prevention. It's it's basically an elderly problem, but also payers, Blue Cross Blue Shield, health systems, my own Kaiser, participate in such. IMPACT, which is our congenital heart disease registry, is being adopted, and the FDA is strongly supporting such. And the Pinnacle Registry, which is the outpatient registry for adherence of secondary measures for coronary disease, heart failure, atrial fibrillation, and diabetes and hypertension. This is being utilized by physicians, as mentioned, to meet PQRS means, with the average person getting $8,400 and 100% successful by using this mechanism. The TVT registry, I just was on a phone call today. We now have 60 hospitals enrolled, with another 50 are in the process of signing up. And what's interesting about the TVT registry is not only to get paid and covered by CMS, you need to participate in the registry, but it is going to be used as a platform for all the post-approval studies that Edwards is required for the FDA. So getting back to what we need to talk about today is how can we make this registry not as an encyclopedic shelfware product, but how can you incorporate it into your practice? So one of the exciting things that's just happened, I don't know if anyone has had a chance to play with this, is the Cath PCI registry has developed a BI tool, a business intelligence tool, where you, rather than just getting a static quarterly report, you can actually interact with the report, harvesting different pieces of data. You can make your own presentations by harvesting the data and things that you want to look at. Drill down, you see a problem, you can actually drill down to individual cases on all the executive summary metrics. You see something and you go, what's really going on this? Is this a data problem, or is this, or can I figure out, is there one physician or somewhere that we can help raise that boat? You'll have that ability to interact with the registry to make it work in the trenches, so to speak. With these, the dashboard, we have the executive summary metrics, we have the performance measures, the trending graphs that you can be able to see how you do over time. As mentioned, drill down to the patient level. You can do unique comparison group filters, something that you might want to do in a hospital system, in the same way that Sandy presented Bob's data. And again, this was just launched. We're also doing this for the ICD registry and also for the ACS registry. And as I mentioned, we are now putting aside funds to try to meet the needs for physician-specific reporting, hopefully within the next year. Those of you who have not seen it, these are what the benchmark reports look like, with a bar and whiskers graph where you can see your performance in relationship to hospitals, and here's a nice example for in terms of, in this case, a PCI in hospital mortality, where you sit, and so forth. And again, here's that business intelligence tool. where this is hard to read, but you can see an electronic report. Oh, I want to look at median time for immediate PCI for STEMI. Oh, I want to look at a PCI process measure. I see the data is then pulled down. You can then export the graph data of this PCI process measure, download it from the chart, put it in a PowerPoint presentation, and then you have a real-time interaction engaging your physicians in terms of what you want to do. What can we do? Well, as we have been talking about already, we have to own our data. It's ours. We need to review the quarterly reports. We need to use these online dashboard business intelligence tools. We need to use this for our maintenance of certification in the Pinnacle PQRS. We need to integrate the workflow in the manners that we can talk about after I'm done. And we need to, and this probably resonates very nicely with Bob, but getting to the heart of the cardiology alignment, we need to know our institution's data. So in this case, these are the metrics of appropriate use criteria. Look at this, understand this, support your role in the hospital with your payers and your contracts. I'm sorry, this didn't show up, but that's shows the actual appropriate use criteria document, and we need to do this because there are questions on what we're doing and how we're practicing. And if we don't do this, us cardiologists and cardiovascular specialists, guaranteed somebody else is going to do it, and we can do it better. We have to be at the table and not the salmon on the menu. So again, here are the Cath PCI metrics. We saw nicely what's happening here a little bit with the variation here within the Providence system. Here's the data last year from the national system and variation of PCI inappropriateness for elective PCI. I will tell you that the Joint Commission has taken this on. So they have an overuse summit. I happen to be participating as the NCDR ACC representative. So they got interested in not just looking at quality, but actually looking at the issue of the overuse. And I find this kind of interesting because it tells you the Joint Commission is also running to the space where they think they need to be. That as we get into payment alignment finally that's properly aligned, they figured out that they need to start thinking about these things. And then the alternative, of course, is this, which is the billboard outside of Pittsburgh that was up this past year after there were some exposés. Was your stent unnecessary? Call Dr. Legal. So that's nothing that we want to see here in Oregon. The common scenarios, inappropriate PCIs. Ty, I don't know if are you going to talk about this or a little bit? But people wonder, what's the real story here? And when you look at most of these indications, just briefly, they tend to be people with no symptoms, people with modest disease, people on no medicine, or people who have stress tests that have no evidence of ischemia or modest combinations of those above. Things that most of us would have no problems with saying that either they're inappropriate or rarely appropriate. And I agree with Sandra about doing this, changing the terminology. For those of you who are interested, there's actually going to be a webinar in 2 days or is that tomorrow? On June 27th. That's today. We missed it. I missed it. We were on a plane. But it talked about thriving with it will be downloadable. But it was actually helping hospital administrators and clinicians trying to negotiate this issue of appropriate use and reimbursement. You could argue that this is a little guild-like, but at least it's going to talk about doing things and documenting on what we need to do. Again, the ACC chapter has chapters that show leadership, particularly Wisconsin and Oregon. We have to deal with the variation of care. It is the enemy of good. I wanted to just briefly say what's going on in Wisconsin. They have taken on, with the purchasers, the payers, and the ACC chapter, diagnosis and treatment of stable ischemic heart disease. And they've used a number of the infrastructure tools that have been created in science and quality within the ACC. One of them, of course, is the registries, which we're talking about tonight. The other are decision support tools that we have in imaging called Focus and Prism. The other is shared decision making, and incorporating all of that to see if we can not only improve care, mechanisms for feedback, and see how that actually affects the cost to the system. So this is for, I put these slides for Sarah. Where are you, Sarah? These are for you. But, you know, an example for informed decision might be an informed decision consent form. So again, I have to acknowledge this happens to be a product that Spertus, John Spertus, has put out in his health outcomes group. You could use his, but you know, you could create your own. But what he did, which I think is fantastic, is that the typical consent form is a generic lawyerese that no one reads. And what he has done is he's taken a consent form and made it an educational tool at a 6th grade level, and then he's embedded the actual patient's clinical scenario into the form. So 85-year-old Mrs. Jones with an NSTEMI, to be able to incorporate and let her know what her actual risk is to the procedure. So her and her family and her cardiologist would know the actual, which most of the time the cardiologist might not guess what the actual risk is, and offer that data so this Mrs. Jones or Mr. Wilson would understand their death rate, their bleeding rate, the risk of restenosis, whether they have bare metal or drug-eluting stents, and we would actually feed this to the form the clinicians, so the clinicians could be better educated, and this is all based on the NCDR data, so this is true evidence-based. And you could even argue you could incorporate the, through our ASSERT grant, which is a grant that we have between the ACC and the STS related to looking at longitudinal management of patients, so that you could take a patient scenario, what their anatomy is, and tell Mrs. Jones what their benefits and risks are, whether they choose a surgical approach, a medical approach, or a PCI approach in terms of all these data. Wouldn't that be a cool tool so they can make their proper thing? Again, it's our professional responsibility. It's the privilege of self-regulation. It sounds onerous, but clearly it's better for us to do it than somebody else. And with doing these things, our clinical practice guidelines, appropriate use criteria, the registry, looking at comparative effectiveness and appropriate use, I think we'll be able to keep continued health and prevent disease, having the right drugs on board. We hopefully can prevent hospitalizations in people who have the disease. And if the patient gets hospitalized with acute syndrome, ensure that they have an efficient, successful outcome through all these tools. And we can do this by reducing costs without rationing. But of course, what's missing is the payment alignment. So hopefully, we can get that soon. I'm going to close with just the issue of public reporting. Surgeons are already doing this. As you know, if you pick up the consumer reports next to your washing machines and toasters, you can read about your surgeons. We are now at the ACC, have put in a policy document about the proper engagement and rules of engagement for public reporting. We have partnerships with Heart Rhythm Society and also SCI in terms of what the hospital level measures might be for, at the present, voluntary reporting. We're coming up on an implementation plan and an execute on who our partners would be. Most likely it's going to be with CMS and Hospital Compare, but just to let you know that's happening. Again, the NCDR is a cornerstone for education, and this was our annual meeting, standing room only, this past year, 850 people there, and I'm really happy to say there were 80 physicians in the room. So all of a sudden, physicians have become interested. Normally, you would ask the quality analyst, what's your #1 problem? What is it? Getting the physician engaged. Now the physicians are becoming more engaged. They want their own clinical track, and I won't go through this. That's our future. So thank you. I hand it over now to Ty, or questions, or?
Why don't you take a couple questions?
Okay. Okay.
Are there any studies to indicate how many minutes or hours a day or a week the average cardiologist, whether interventional or not, will spend allowing this data to be collected?
So I'm going to translate that question. I think the question that I would be asking as a cardiologist, I'm working too hard already. I can barely get through the workday. This is another thing that's onerous. How much time are you asking me to spend to do such? Is that you were being kind when you asked the question? And so the challenge that we have to have is we have to make it seamless. It hasn't been seamless, so that's why physicians haven't been engaged, and we hire the quality analysts. So until it's seamless and in the workflow, it will be onerous. The good news is that in Pinnacle, it is now incorporated into the workflow. So as opposed to having a standalone registry, Pinnacle actually extracts the information directly from the EHR and offers prompts and decision tools to help the physician as opposed to being in the way. But we still have a ways to go.
So I just wanted to comment on that because realistically, I think it might take 5 to 7 minutes while somebody's note of documenting the appropriate information for this. And this is a $20,000 procedure, maybe. And so I would think it's unreasonable to ask that the information's there that creates the transparency necessary to show until the appropriateness is good and can be reliable and can be demonstrated across all communities. To ask somebody to spend 5 or 6 minutes for a $20,000 procedure.
So, you know, of course, we're talking about, just in terms of the appropriateness thing, Bob, 90 seconds. It's not even that hard.
I'm being kind.
You know, it's 90 seconds, but in terms of all the other things, it's more. But it has to be in the workflow and prospective. Now, if you ask the people behind you how long it takes them to do it retrospectively, it's 30 minutes or so to go through a chart. You know, they're loving listening to this, that it could be done prospectively.
How much of the $20,000 does a cardiologist get?
Well, yeah, but it's not really relevant. You know, I mean, so if you ask me as a payer, if you ask me as a payer, would I be willing to say, I estimate just from our data, we started with the PED population, that I think that reducing the variation to them, which is not our money, it's their money, is probably $10 million on the variation in cardiac spend across the state. $10 million. And so every dollar they have to spend on that on benefits is a job loss. You know, some of those are teachers, whatever. Maybe it's benefit sharing, maybe it's increased co-pays that detracts their care from you. And I do think a portion of that, we need to find ways to share that with you so that when you see your use rates go down, you don't see your incomes go down. What's harder about that is in areas where there's not multiple payers willing to do that. But I tell you, we're willing to do that because you can't be penalized for doing the right thing.
Ty, did you have a question?
I just had a question and maybe Jim can answer this as well. From an advocacy standpoint, NCDR started out about quality and comparing data, learning from it, and leading to initiatives to improve performance. More and more, whether it's the litigious side of things or it's the payer side of things, there is a growing fear amongst providers. This is being leveraged now to adjust payment. And I just wonder where, we're in Oregon, but where you hear around the country, is there a sense of fear? I think we're more engaged, but is there a sense of fear this is being leveraged to do that much more? And this gets through, obviously, all the information that's displayed out publicly, or public reporting, but I would welcome, from an advocacy perspective, what you're seeing people concerned about.
Oh, I'm Jim Fasoulis. I'm with the college. I'm the one who's waiting to see what the Supreme Court says tomorrow because I have to be responsible for preparing part of the response. I would say that's the way it's going to be. Now, let me change things around a little bit too, and we've confused guidelines with appropriate use criteria, with registries. We kind of use them interspersed. Theoretically, the way it should be, and this is what Medicare is doing with the ICD, is the ICD is based on guidelines. It's not based on appropriate use criteria. Appropriate use criteria is ideally helping you to match the guidelines to your care. It's a CQI tool to help you with the guidelines. More and more, they're being picked up by the radiology benefit management or things like that to be coverage determinations, but they weren't built for the coverage determination aspects. So we constantly are trying to remind people that appropriate use criteria are to help you improve your care and should be used for CQI and not on coverage. I kind of went around your question a little bit, but that's what the message we take to the Hill and with the payers.
I'm sure with the registries for TAVR, for example, and the other registries, if your data are not good, you will not be paid.
Well, it isn't whether your data is good or not. You have to be in the registry to get paid first.
And then if you don't perform,
And yet, even with the ICD, they haven't used what they showed. They were out of compliance with the coverage determination, which is different than first off, everyone thought it was an appropriate use criteria. There are no appropriate use criteria for ICDs. But this whole article didn't involve that. It was strictly the coverage determinations because they took the guidelines chunk, but the guidelines has a statement that the physician's opinion and decision can trump all the guidelines. But when you put it into a coverage determination, it's black and white. And of course, we can go in all the variations that it says 90 days. So if you put the ICD in it, 89 days, you're out of compliance. I mean,
Here, I can walk around. You can use it.
No, this is good.
Thanks. So I'm really concerned that the registries are missing a huge issue, and that's the patient viewpoint. And there are a couple of issues that I think about. One is the patient's function, their cognitive status, as well as their physical function. And the other is the ability to track outcomes. And looking at these registries, they capture a point in time, and they don't tell us what happens down the road. And I think the ACC is really missing a real opportunity to find out what works and what doesn't work well for certain people. I would encourage you both to try to incorporate some component of either patient preference or patient functional / cognitive status up front. But yes, I am talking about your mother, because your mother and everybody else who's friends with your mother has heart disease.